Hello, everybody. I'm Donna White, founder of the BHRT Training Academy. I am excited to have you with us today on this master's level training. Our master's level training is for the providers in our community to learn more. It's an opportunity to learn more, take a deeper dive in subjects. We always try to bring you topics that are relevant to your BHRT or TRT practice, whether it be more clinical information or business or marketing. So we hope that you enjoy this material as much as we enjoy bringing it to you. So today, I'm really excited, and we've had a lot of requests for this information for more help with dealing with PMDD and PMS. Sometimes patients are so easy. You can give a postmenopausal woman estrogen, progesterone, testosterone, whatever's indicated, and change her life. And it's so easy and it's all great. But then there are some patients, whether they're perimenopausal or especially the PMS, the PMDD, you've done everything you knew to do. You gave them the progesterone or whatever, you dealt with cortisol, you did everything you could, but they're still not getting the response that you hoped. And perhaps, Diana, that's why you did a deeper dive into this, because you just like the rest of everybody on here, you really want to help your patients. So give us just a little bit of background. I know you did this study as a part of your doctoral program. Congratulations. We are all so proud of you. But tell us a little bit about why you did. You're an expert in hormones. You're one of our mentors. You've been with the Academy since we opened. So tell us why you did that, and then just go right in and start teaching us. And thank you so much for doing this for us.
I'm going to take a brief pause. My little thing is spinning. It's giving me notification. I need to get a better connection. So I'm going to grab an extender real quick. Did you push record yet, Donna?
I sure did.
Yeah, I'm so sorry. Let me grab that because it's going to be a long course. If we don't.
Okay, so some of the things we normally think of when we start thinking about PMS is that it's happening to younger women, whether they're 20s, 30s, and sometimes it is very easy to give them some progesterone, get their nutrition in order, getting carbs down, supporting them with fiber and just good blood sugar balancing nutrition. Sometimes that absolutely does fix it, but then sometimes it doesn't. That's when we have to think and dive a little bit deeper. And those are the resources that I'm hoping, or I'm excited that Diana's going to bring to this. Because again, sometimes these patients respond, and then sometimes it takes a whole lot more work. So that's what we'll be talking about today. I see a great crowd joining us. Thank you so much. This replay, Diana did send the slides, so we'll send those out with the replay. The replay for master's levels usually take about a week, and we send them out. We put them on our Facebook group page. We send them out to you in an email, and we also put them in the training portal. So there'll be a replay of this in the training portal in the master's level section, and we'll put her slides along with it. So with that, are we ready to go, Diana?
Ready.
Okay.
Thank you so much, Donna, for that introduction. So I am Diana Williams. I am a board certified family nurse practitioner. I'm also certified by the Institute of Functional Medicine and Functional Medicine, and recently graduated with my doctor of nursing practice from Duke University. So a lot of the learning that we're going to do today is all the learning that I've been doing over that course of my mini research project I did with Duke in compliance with my DNP project. It's about a cumulative about 3.5 years of research and education, and then very, very close to publication. So we're really excited to get this information out to people. But I think the reason why I chose this project in conjunction with my DNP education was because even with the functional medicine principles that I already knew and were using, I still was struggling with this very unique subset of people with severe PMS and PMDD. They were getting a little bit better, and actually some people were actually getting worse with my treatment. I was trying to treat it as a PMS case, and I was learning that it was not the same. We were looking at two completely different bears, and they have to be treated very differently. So I took a very deep dive into the research. I did a mini research project with about a cohort of about 12 women and got some really good outcomes. But in this, I'm going to actually show you a lot of the pathophysiology as well. So let's go ahead and move forward and see if I can get the slides to work. All right, it's going to freeze up on me. I don't know if it's my computer or my internet. Donna, you may have to take over and just move forward there.
All right. I don't know that I can advance this. Okay, let me pull up your slides from my email. You give it a shot while I'm working on it on my end.
Fine.
Okay, is it work? Is it going? Okay, is it going on your end?
It's still struggling, but it looks like it's trying.
Okay.
It's a really good project, guys. I promise. If I can get it to you, you're gonna love it.
Okay. All right. You can see my screen, I think. Can you see? Somebody give us a heads up in chat if this is showing. Can you see it, Diana?
I cannot, but I think it's my computer. All right, there we go. Now we're showing it.
Okay. Are you seeing my screen or yours?
I can see yours now.
Why can't I advance the slide? Oh, okay. Apologies, everybody. We came on 10 minutes early to get this all straightened out, but
Yeah, mine's completely frozen.
okay. All right. Can you see mine?
Yes.
All right.
All right, so just a very brief introduction. Again, I am Diana Williams, and this is a brief introduction about what we're going to be talking about today. So we're going to deep dive into the pathophysiology. We're going to talk about how to treat PMDD and severe PMS. I'm going to go into a little bit of the actual research that I did, and then we'll have some time at the very end for a little Q&A. All right, so this is just an interesting, in my deep dive, trying to really fully understand like the history of what the brain ovarian axis looks like. So for years and years and years, we've been talking about as far back as like Greek mythology, and then also like Hippocrates' time. There were roots of trying to understand what was happening with these women. The word hysteria comes from the Greek term hysteria. Very close to how we get the word hysterectomy. And interestingly enough, a hysterectomy was and sometimes still is the treatment of choice for patients with severe mental disorders that we believe are more of a reproductive kind of background. So Hippocrates actually was one of the physicians that believed that this was solely a reproductive disorder. Anytime a woman would come in with any kind of mood complaint, so irritability, tearfulness, like just that typical PMS symptoms that we would think of today, we would slap a diagnosis on or a label on there, and we would think for sure she's crazy, she's hysterical. And they actually believe that what was happening is the womb was actually wandering. So the uterus was not in the pelvic floor where we believe it is now. It actually would start to move around the body. So we thought that if she was really hysterical, it's because it was too close to her heart or too close to her brain. There were also even theories that it was compressing on her chest where she couldn't breathe. And that was causing a lot of these women to just pass out. So there's just a lot of like fun background into that, but kind of fast forward, their solution for years, even centuries, was that a woman who had this reproductive disorder, the solution was more sex, more babies. So that was their prescription, was have more sex. That's your root cause. Your womb wants to be full of babies at all times. If you're not pregnant, you're going to go crazy. So therefore just have lots of babies. That was their prescription for, and these were well known for not just decades, but centuries. Enter Sigmund Freud. He actually started saying, okay, maybe hysterica is not so much of a reproductive disorder, it's more of a neurological disorder. But interestingly enough, his prescription was the same: have more sex, have more babies. It was an issue with low libido, and that was the prescription back then. So then fast forward to like the 1950s, we started actually learning that maybe it's more of a psychological disorder. We actually took the word hysteria out of the DSM-5 at that point, thinking that, yeah, maybe we really don't have it figured out. So the question is this a reproductive disorder? Is it a neurological disorder? Is it a psychological disorder? The answer is yes. It really is all of the above, and we're going to talk more about the science behind all that. So PMS is a very high prevalence rate in the United States. So this is a US data. So it's about 70 to 90% of females of reproductive age have some aspect of symptoms of PMS. Unfortunately, PMDD is its own bear. It actually affects anywhere, some of the research says 2 to 5%. Some of the research is saying upwards of 3 to 8% of women of reproductive age. So you can see it's a small fraction of women actually have this diagnosis. And what I found through my research is that's pretty consistent along ethnical backgrounds as well. There was some studies that were done in India. There were studies that were done in South America. They were all consistent with this, either 2 to 5 or 3 to 8% of the population. So it doesn't seem to affect American women any differently than the rest of the world. The main difference between the diagnosis of PMS and PMDD is the frequency of symptoms and the severity of the timeline too. So typically the timing of the symptoms, most of the PMS is going to happen right after ovulation. We see this start rise in the LH hormone and then a rise in FSH as well, promoting ovulation. You get a surge of progesterone. And then we see those symptoms starting to come into play. So the symptoms for PMS are typically mild to moderate, we're calling them, and the timeline is roughly the same. With the stark difference between PMS and PMDD is these women with PMDD get significantly better at the follicular phase. So as soon as they start bleeding, their symptoms almost always completely resolve. PMS can kind of linger a little bit longer, and it's not near as severe. But the timing of that is not the only criteria to meet diagnostic criteria, because some women actually do fine up until about day 6 of their cycle, and then it intensifies until about 2 days before menses. So there's some variation in terms of the timeline, but the biggest difference is the severity of the symptoms before then. So you have to have certain criteria to actually meet the DSM-5 criteria to call it to moving in from moderate PMS to what we call PMDD. And honestly, I think the terms severe PMS are basically the same as PMDD. Once you get to that, the subjective complaint of a patient saying, I have severe PMS symptoms, really start looking for a PMDD diagnosis, and therefore you have to change your treatment plan because of that. All right, so the symptoms of PMS and PMD, remember the symptoms are pretty similar, but we're going to talk about the severity on the next page when we look at the DSM-5 criteria. You're going to see anywhere from mood swings, irritability. A lot of times it's a significant of agitation and anxiety. You're going to see more likely. Sometimes you're going to see more depression, energy changes, appetite and food cravings. You're going to see some fluctuation in weight. Sleep disturbances, and even physical symptoms, so like headaches, bloating, breast tenderness, all of those can be combined with PMS and PMDD. So the DSM-5 criteria, and these are more recent updates, they're actually saying that you have to have at least 5 of the 11 symptoms that occur at least the week before menstruation and actually improve just the day of or a few days after bleeding starts. So you have to have 5 of the following to actually have a diagnosis. And the symptoms also, not just you have to have at least 5 of the 11, the symptoms have to be severe enough to actually interfere with daily activities. Therefore, you're going to see these patients calling out of work. They're going to call out of social events. A lot of times these women can actually be bedridden those days of their cycle, which if you count out 2 weeks of every cycle of every reproductive, during the entire time they're in the reproductive cycles, that's a lot of missed activities. That's a lot of missed life for these women. And in severe cases, actually suicidality is definitely an increased risk. This is one of those you may want to like keep in your desk somewhere, have this ready, have this handy. You have to have at least 5 symptoms. These symptoms are typically what you're going to see. So these 5 symptoms have to be present: the depressed mood, feelings of hopelessness, marked anxiety, sudden feelings of sadness, anger, irritability, decreased interest in activities, and decreased energy. And again, these have to be severe enough to interfere with their daily activities. So this is the current ACOG recommendations on treatment for PMDD. Their treatment options for PMS are slightly different, but when you're talking about PMDD, sometimes is a lot more limited as far as effectiveness. So they put out these guidelines. They updated them actually late November of this year, or this past year, excuse me. And they're saying the strong recommendations are still, unfortunately, SSRI use. So that's usually first line. And then the low to moderate, they're saying, okay, if the SSRIs don't work, you can consider doing cognitive behavioral therapy. And then if that doesn't work, you can consider doing the combined oral contraceptives. There are some additional conditional recommendations. So these have more of a lower quality of evidence. There have been some benefit with GnRH agonists, and those work very similarly to what's happening with the oral contraceptives. Is it basically just kind of disrupts what's going on between the brain and the ovaries themselves. So it disrupts that communication. Therefore, most of the times they're not even going to ovulate. It's a little bit upper tier, upper stream approach than the combined oral contraceptives that works a little bit downstream, but the gist is the same. It's where you're basically not ovulating, so you're not getting those LH, FSH, and estrogen progesterone curves. And they do give a conditional recommendation. It's a low quality of evidence, but at least it showed up on their recommendation. So it's happy to see that they do recommend exercise, calcium supplementation, acupuncture, educational coping strategies, and then they said NSAIDs for just the symptoms related to pain and inflammation. And then unfortunately, if all else fails, they say as a good practice point, that basically means when all else fails, this is what the experts do, is rip your uterus and your ovaries out, and then maybe refer to a behavioral health counselor. So that's unfortunately what our recommendations are currently. So you've got medications, you've got maybe try some exercise and calcium, and then you said, then if all else fails, rip their ovaries and their uterus out. Which I'm being dramatic, but guys get my point. This is not great recommendations. This is not a great algorithm for treating these patients. So there are obviously a lot of limitations to pharmacological therapies. Not everyone is going to be a candidate for SSRIs. There are side effects, including weight gain, nausea, diarrhea, changes in sexual function. They're limited in effectiveness. Only 51 to 57% of the time do patients actually get a reduction in their symptoms. And that's based on current standard of care, which is SSRI therapy. Those studies were a little bit of a mixed study, but they were done predominantly on fluoxetine, sertraline, and then paroxetine. So those are the top 3 that we're using in the research. Those are the top 3 that the gynecologists are prescribing. But again, only 51 to 57% of the time they're actually effective. Interestingly enough, birth control is even much lower than that. So we're talking about 40% effectiveness for using birth control for these women for symptom management. And then there's a high discontinuation rate. A lot of people stop their SSRIs because of poor outcomes and and a lot of side effects. So there's actually a 43% discontinuation rate of medication at 12 weeks and as high as 73% at 6 months of therapy. And then, of course, there's just an increased demand. There's all these TikTok influencers. We're in the world of people actually searching and trying to look for a more holistic and comprehensive way to approach their conditions. And there are recent studies that have been shown that 80% of females prefer using natural and or herbal therapies to treat their symptoms versus medication. So people are going to start coming to you because they're asking for an additional support. They don't want to either take medication or they tried it and failed it. So we need to make sure that we're armed and ready to help these people. So in functional medicine, we're taught to really understand what the root causes is. So we deep dive into literature, help me to identify these are the contributing factors that we know of, specifically for PMDD. Now, some of these are going to be a crossover course and be a contributing factor in PMS. So most of the things I'm going to teach you on are going to be you are able to obviously using lifestyle-based medicine to address them all. But there are some genetic factors that are been associated with an increased risk for PMDD. There's a couple polymorphisms, or SNPs is the common terminology that we use. One is for the 5-HT receptor. So those are serotonin receptors. So we know that there is a polymorphism associated with PMDD on the serotonin receptors. There has also been associated a polymorphism on the estrogen detoxifying pathways for these clients as well that have PMDD. And those are particularly estrogen beta receptors are going to be affected. So genetics are going to play a role. Again, we in functional medicine know that that's not the end all be all. It's the genes that load the gun, but it's the diet, the lifestyle that we bathe those genes in that actually turn those genes on and off. So this is why the functional medicine approach works well for these clients. There have been some associated gut dysbiosis and inflammation in the intestines. We obviously can assume that because we believe that most diseases begin in the gut. And the gut is the second brain. So whatever's happening in the gut is going to, at least to some degree, affect the brain. Now, that does not completely tell the picture of why that PMDD is happening so severely just the last 2 weeks of the menstrual cycle. So we know it's more than just gut dysbiosis, but it can certainly be a contributing factor. Obviously hormonal imbalances, but this is not just as simple as estrogen progesterone. If that were the case, then we would give these people with PMDD progesterone and they would feel better like they do with PMS, but this is not what we're seeing for this patient population. And that is probably the most important takeaway that you're going to get from this speech today. And I will deep dive into that in just a moment. Inflammation is going to be associated, of course, the inflammation in the brain, the inflammation in the receptors, and we have seen a significant increase in inflammatory cytokines and interleukins and hsCRP markers in patients with PMDD. So there's a huge inflammatory component to it. And then we've seen nutrient deficiencies as well. There's been deficiencies in magnesium, B vitamins, vitamin A as well. Calcium deficiencies and omega-3 fatty acid deficiencies have all been implicated with PMDD cases. This contributing more contributing factors here, toxins. We know that endocrine disrupting chemicals are associated with increased risk of PMDD. Smoking, someone did a study that was specifically on smoking. Smoking increases the risk by 2 times more likely to have PMDD, specifically if they were smoking in adolescence. Now, that risk does not, unfortunately, go away for former smokers. It continues throughout the lifestyle. So if you have any history of toxin or smoking, specifically in adolescence, you're 2 times as likely to develop PMDD. That's unfortunate, but that is the reality that we have. Obesity is a higher increase as well. There's for each 1 kilogram increase in weight, there's a 3% increase in the risk of PMS. Now, this one was specifically on PMS, but there was an additional study that showed BMI was higher. BMI higher than 27.5, the PMDD risk also raised as well. So obesity is not good for either one of these conditions. Past history of trauma, any kind of psychological trauma, specifically with other comorbid behaviors, things like bipolar, major depressive disorder, those are also highly associated. I think another key point here is to recognize that it's important to screen for these other comorbid conditions, because sometimes they look very similar, right? They look like bipolar disorder, they look like major depressive disorder, and they look like general anxiety disorder. So patients get misdiagnosed and mistreated. They put them on a whole bunch of other things that are more band-aid approach without treating the root cause. So I think it's important as a practitioner to make sure we're comfortable screening for the comorbid conditions as well. And then obviously sedentary lifestyle. So not moving your body, not exercise is highly associated with PMDD and PMS. So as far as endocrinology, neurology, neurobiology. We're talking about the hormones associated with PMS and PMDD. And you can see here, there's a laundry list of these things, right? So this is where the majority of the research is going into. For a long time, we thought it was just a serotonin deficiency. So we were treating it the same way we were treating major depressive disorder or general anxiety disorder and giving them serotonin drugs. Again, we know that that's not only the case. There is a factor of serotonin because of the way the serotonin talks to the GABA receptors, but newer emerging data, and I say emerging, we've actually known since the 1980s that there was more of a GABA response in the brain. There's something going on with the GABA receptors. But we're now just starting to deep dive and really trying to figure out exactly what's happening at the GABA receptor site. So this is, yes, a serotonin issue. Yes, a norepinephrine. Yes, a dopamine's all associated. Yes, progesterone and estrogen, of course, are associated. But predominantly, we need a deep dive into this GABA. And that's where a lot of my research has been, is trying to figure out what's actually happening at the GABA site. And that's what makes this PMS and PMD very different. So PMS patients come in, a lot of times you're going to see them clinically with low estrogen levels, and they're going to have low GABA levels as well. They're going to have low progesterone levels and sometimes estrogen dominance is what I was trying to say. So low progesterone, estrogen dominant type patients, you give them progesterone. Specifically, if you give them oral progesterone, you're going to get a little bit more of those allopregnanolone metabolites that work on the GABA receptors, and you can almost see immediate relief of these people. They calm down, they're sleeping better, they're less irritable, they're cramping, their breast pain, all that improves very quickly with adding some progesterone. That is not what you're seeing in these PMDD cases. So if you have a true PMDD case, you can actually make this process significantly worse. And I have a chart to show you what's going on. Now, and this is just what I've seen from the data. I've had to compile a whole bunch of other research to actually get this tiny little chart. And I'm still missing a couple things here because there's just not that evidence yet. But in PMS, you're going to see typically a low serotonin. We don't really know with PMDD. You're going to see a low GABA response in PMS. Remember, it's the allopregnanolone that converts to GABA, allopregnanolone that works on the GABA A receptor site that activates those GABA receptors. In PMS, that's where you're going to see relief of their symptoms. So if you can actually raise their or activate their GABA sites, you're not truly raising GABA, you're activating those GABA sites by increasing allopregnanolone, by giving them progesterone. In PMS, you see a result, but that's not what you're seeing with PMDD. The research is actually showing that we have a high amount of allopregnanolone in people with PMDD. It is not deficient, it is high. So what the heck is going on there to make those levels high? There's a chart on the next page, and I'll show you a little bit more in detail what's actually going on here. But to kind of point out also the GABA is low in PMDD, but that's not necessarily the root cause. Typically what's happening with GABA is actually converting to glutamate. So glutamate is your excitatory neurotransmitter. So you get anxious, you get wired, and it's actually not as well talked about as a neurotransmitter, but it is considered your mother neurotransmitter. It kind of talks to all the other ones, and it can act on just about all the other receptors as well. So glutamate is really, really important to understand when you're talking about the pathophysiology in PMDD, but that glutamate levels are actually associated, they're actually high in PMDD. Estrogen is typically high in PMS, and it actually is normal in most PMDD cases, not all of them. Progesterone levels are low with PMS, and they're typically normal in PMDD cases. So very stark differences in your neurobiology with what's actually happening between these two cases. And Dawn, I think you disappeared, but I'm ready for the next slide. I know this is a lot to kind of swallow, so we're going to go into this. I'm going to reiterate this a few different ways so you can kind of grasp it as best as possible. Sorry, this is an additional slide. So this one's just basically reminding you that all of your hormones are conjugated. They're made from cholesterol, right? So cholesterol converts to pregnenolone, and then the pregnenolone actually goes down these pathways to produce progesterone. depending on what's happening at the enzymes, like how, if the enzyme activity is actually upregulated or downregulated, depending on what's going on inside the body and or genetically, you're going to see this progesterone pathway shove it more down the allopregnanolone, or of course it can go into cortisol as well. And we know the steroidogenic pathway also takes that progesterone, turns it into 17-hydroxyprogesterone and goes down these androgen pathways to actually produce your estrogen as well. So all that to say is that there's a lot kind of going on here, but also when you see a lot of PMS patients, think a little bit further upstream. So if it's a true PMS and not a PMDD, I always look at their cholesterol levels. Sometimes you'll see these women that have progesterone deficiencies. It's generally one or two things. A, they're not producing enough cholesterol or not ingesting enough cholesterol to make pregnenolone. That's very common. So especially your underweight people, or they're not getting enough omega-3 or healthy omega-3s in their diet, they're cholesterol deficient, therefore they're pregnenolone deficient, and they're just kind of deficient in all their hormones. Then think very high upstream and make sure you're supplementing with some good quality omega-3 fatty acids. But also the cortisol steal. I'm not going to go too much in detail about that, but as you can see, the cortisol's at the bottom. When the body's under a lot of psychological and physiological stress, it's going to upregulate all these enzymes and shove that wonderful progesterone down to cortisol, which is more excitatory and inflammatory, has inflammatory components as well. So I want to make sure that we're thinking upstream and downstream when we're thinking about just a PMS diagnosis, because the treatment for PMS is upregulating that allopregnanolone. The treatment for PMDD is not, and I'll show you that in the next slide. All right, so this is the chart I've come up with. This took me only a few weeks to to put this all together, but there's there's not one research that shows all this, so I had to kind of like grab from a few different research articles to kind of figure out exactly what's happening here. But the current theory behind PMDD, and again, this is not confirmed, this is all theological or theoretical right now, is an altered sensitivity of the GABAergic central inhibitory system to allopregnanolone. So allopregnanolone is the bad guy in PMDD, which is really sad, but that's exactly what's happening. And it really is more of a Goldilocks phenomenon where you have to have just enough to work on the GABA receptors. But what's happening with PMDD is that they are flooded. These patients have way too much allopregnanolone, and they're flooding the GABA receptors in the brain, where the actual GABA hormone doesn't work because it doesn't have a site to attach to because there's so much allopregnanolone. And then, like most excess with hormones, there is a down regulation of these receptor sites. So that's exactly what's happening. So we're seeing the GABA receptors are down regulating because of the flood of allopregnanolone. So let's work upstream. Let's figure out exactly what's happening here. So there's a couple ways in functional medicine that we can intervene to get better results. Number one, you need to look at that progesterone pathway. Typically, you're not going to see a low progesterone level in PMDD. So it's not a case where I'm going to try to supplement a whole bunch of progesterone. I did it first when I first started practice. And it just wasn't working. So I thought if a little didn't work, I'd give more. So I'd flood them with about 300 milligrams of progesterone, and then I would lose them to follow up. No joke. Most of these patients just went away and they never came back to me. They were like, okay, this girl doesn't know what she's doing. I'm getting much worse. I give up. And most of them, I lost to follow up, unfortunately. So I have learned quite a bit from them to not flood them with progesterone, thinking I'm helping them. You can actually do much more harm than good in this case. So reductase, which is the 5-alpha-1, this reductase 1, there's a couple different enzymes that are included here. And we know that the 5-alpha reductase is also important with the testosterone pathways. So what we're trying to do is helping support lowering that 5-alpha reductase enzyme. So if we can work way upstream, we can stop the progesterone conversion to its metabolite, which is 5-alpha dihydroprogesterone. So things that increase 5-alpha reductase is high insulin level. So you probably will see a correlation with insulin resistance in your PMDD patients. You're going to see an increased adipose tissue in them. And then, of course, these serotonin and estrogen polymorphisms. I have the estrogen polymorphism. I did not write it down, but it's the serotonin is what you're seeing here. But there are a couple different polymorphisms here. So if you have any of these things, you're going to upregulate it and you're going to put progesterone down to 5-alpha dihydroprogesterone, which is not what you want. You can downregulate these with natural 5-alpha reductase inhibitors. So these are the ones that you typically use for your males. These are things like beta-sitosterol, quercetin, saw palmetto, pygeum extract, black cohosh, nettle root, all those wonderful things actually slow this enzyme activity down. Oral contraceptives also work by this inhibitory effect. And then in medications, if you're looking for medications to use, you can do dutasteride or finasteride. Those will help support these patients. So that's interesting. I did not know that when I first came into this, is the 5-alpha reductase was what's sending all this down the allopregnanolone pathway. And then once you get to the that metabolite, you need another conversion to get for the 5-alpha dihydroprogesterone to allopregnanolone. So there's another enzyme, a dehydrogenase enzyme, and there's actually 2 or 3 of them in that pathway that actually shove all that down allopregnanolone. So we know that that process is going to also increase by stress and cortisol, inflammation, alcohol, and then other polymorphisms. The things that downregulate these, and I need to update that for you, Don. I think my slides were updated, but yours were not, are nutrients. So this is where your nutrients come into play. So you're actually going to see a calcium and vitamin D. They actually will come in another pathways way, and I'll show you that. So, but all this to say is if you're going to help modulate this particular conversion, you need to get them off of alcohol, lower their inflammation, lower their cortisol as well. And then the allopregnanolone, that's the bad guy, right? We've got too much of that. We're flooding the GABA receptors. It's blocking natural GABA from getting to the receptor site, and it's also downregulating receptors. So there's a way you can help support these patients. There's medications on the market right now that actually downregulate that. There's only one that's actually new to market. It's called sopranolone. Sopranolone is getting some really good attention right now for PMDD cases. So it is a viable option if you're trying to treat it with a medicine, and if you're at a severe level, if this patient's been, pretty severe symptoms, you can certainly intervene with that, all the while you're doing more of your functional medicine practices. What increases this GABA is a medication called brexanolone. Brexanolone actually upregulates the GABA, and it is indicated for postpartum depression. So that's our postpartum depression case. It's basically is allopregnanolone is what it is. So that again, postpartum depression, PMS, those are good allopregnanolone. We need that more of allopregnanolone. So we're going to give them that, but not in your PMDD patient. You want to block it as much as possible. And then there's this pesky little glutamate. So we were talking about glutamate earlier. So remember, GABA's calming, it's inhibitory, glutamate is excitatory. So in cases of high glutamate activity, you're going to see an upregulation in this GABA receptor, which is not good. Foods that are high in glutamate are things like gluten, dairy, and soy. So getting your patients off of these things can help slow down this process. And then this is another way to intervene with nutrients. So calcium, omega-3 fatty acids, vitamin D, and magnesium all down-regulate this glutamate to GABA production. So that kind of blocks it at the receptor site. So again, this is where the inflammation comes into play. This is where the dietary comes into play. This is where your herbs and nutraceuticals come into play. So there's a lot of different pathways that we can work on to help these patients. These are just some clinical cases that I saw early on in my practice. Now, these were not part of my case studies. Unfortunately, the research did not allow me to do any baseline testing on them because that would have been a formal research trial, and I could not do that with the quality improvement project that we did. But these are just patients that I have seen in my practice pre-intervention. So these were their baseline. They came to me with a diagnosis of PMDD, and I want to kind of show you what I'm saying is this is what I typically see in clinical practice. So some of this is just my little clinical pearls. This is their baseline. This lady, 24-year-old PMDD pace, her progesterone levels are not low. Now, these are progesterone metabolites, right? But, when we're looking at it clinically, it doesn't look like she's very deficient in progesterone. It doesn't look like she's deficient in estrogen. Even her testosterone levels are not that significant. Now, she does have quite a bit of DHEA production, which we think that has something to do with her adrenal glands. So you'll see with her, she's kind of low cortisol in the morning, high cortisol throughout the rest of the day. But you're going to see some variance in what's actually happening with the adrenal glands. I did also show her 4-hydroxy metabolism. I'm not seeing a high 4-hydroxy for her, but you will see it with some of the other clients that I'm going to show you. Another key point to kind of look at here is this alpha pregnenolone. That particular one, so you've got a beta and you've got alpha metabolites of that progesterone. These alpha metabolites, those are the ones that are more likely to convert to allopregnanolone. So if you get a Dutch panel, you see that high activity, just start thinking, yeah, you might be looking at a high production of allopregnanolone. Again, a good thing for PMS, a bad thing for PMDD. So something just to kind of to look at. We'll go ahead and rush through the next few. I think there's 4 of those, just so you can see what I'm seeing. All right, so this is a 45-year-old, very same picture, right? Her testosterone levels might be a little bit lower, but her progesterone levels are not low, estrogen levels are not low. She does have a high 4-hydroxy though. So there is, again, those estrogen receptor SNPs, that's where this kind of comes into play as well. So we are going to help modulate that with our plan of care. Her adrenals look decent. Here's another one. Her estrogen levels actually were low. Progesterone metabolites look pretty good. Adrenals look pretty decent, not great. She did have a significantly elevation in her 4-hydroxy pathway at a 33-year-old. And then it's our last one. So again, 44 years old, decent progesterone, maybe lower end of normal estrogen, did see a high 4-hydroxy here. That wasn't consistent with all the cases, but it did seem to be trending upwards. But what I wanted you to take away here is your patients most likely are not progesterone deficient. It's not truly a progesterone deficiency case. So giving them progesterone is not going to fix the problem. All right. So I think it's important to know how to screen these patients, right? So we know how to diagnose them based on their DSM-5 criteria, but it's a good kind of to monitor their progress. What I've seen is that it's going to take a good 12 weeks for you to see really good outcomes with these patients. And it is a chronic condition, right? So they're always going to struggle with this genetically as such. So we need to make sure that we're monitoring, finding out a baseline, how they're doing. There's different screens that you can do to kind of see what their baseline scores are. So this kind of gives you an objective score for them. The one that I use in my study was the daily record of severity of problems, but there's a couple other ones that you can do. So make sure that you're using these to kind of show improvement in outcomes. This is just what the PMS tracker that I use, the daily record of severity problems. You can see it's annoying. Patients hate doing these. And that was one of the outcome barriers to our data analysis, is like people just got tired of doing these. So it kind of messed up my little clinical trial a little bit. But it's very, very helpful. And there's about 21 different questions there, different categories. So in my little case study, I did originally recruited 12 people from my area. 3 of them dropped out. So I had 9 that I finished with. They already had a diagnosis of PMDD. I did not medicate them. I didn't prescribe any medication. So this was all lifestyle and supplement-based regimen. And then we did not ask them to stop or change their current medication. We did a pre-test with the DRSP scores to get a baseline, and then we had them track daily their DRSP scores throughout the program, and we measured again at the end of a 12-week intervention phase. So we followed them total for 16 weeks, 4 weeks of their cycle before starting the intervention, and 12 weeks of intervention. So the key areas to address. So I basically created these modules based on what the research we just talked about, what the research said about these lifestyle-based interventions. We addressed their nutrition, their toxins, their movement, and their stress. And then also we gave them nutraceutical supplementation as well. So those were the 4, 5 areas that we intervened with. So we prescribed to them a Mediterranean-based diet. And I'll be honest with you, the research on diet with PMDD was non-existent. There was nothing out there. So I had to pick and choose. I chose a Mediterranean-based food plan just because of my background, my knowledge that it's an anti-inflammatory food plan. It has been studied with postpartum women for postpartum depression and with good outcomes. And it has been studied with just general mood disorders with good outcomes. So I thought, hey, let's give it a shot. Let's see if this is going to work. Just because all the wonderful things we know about the Mediterranean diet. It's high in phytoestrogens because of, flax seeds, sesame seeds, those kind of things that can help support and balance hormones. It's high in omega-3 fatty acids, which are general anti-inflammatory. It is high in magnesium through dietary sources like avocado, nuts, and seeds, and spinach. And it was high on fat-soluble vitamins from meat, eggs, lentils. All those are great for metabolism, energy, and neurotransmitter support as well. It's high in fiber and in low in inflammatory foods. So we did ask our patients to cut out seed oils, sugar, gluten, alcohol, caffeine, and heavily processed foods throughout their intervention stage. We gave them a lot of good resources. I think that when you tell patients go on this diet, don't eat these things, they need some resources, right? So we try to dumb it down for them as much as possible. I firmly believe that information is power. If you can truly inform patients as what's happening inside their body and how they can use food to fix it, it kind of gives them agency over their diagnosis and over their concern to kind of help them long term. So it gave them lots of resources here. We can kind of flip on through those. Told them roughly not so much of a calorie intake, but a serving size, like what a good serving size would be based on their body weight. So these are general recommendations, but basically it's derived from the IFM food plans. That's where I got most of this information and modified it. You can flip to the next one. That's just page 2 of the diet. We did talk about blood sugar balancing to help support the adrenal glands. We can skip on through. Gave them some recipes. Next slide. The next module was about movement. So in the research, we know that the elevation in BMI and lack of physical activity increases the risk for PMDD. We know that regular exercise, regardless of the type of exercise it is, has an improvement with PMDD, not only the mental, but the physical aspects as well. Next slide. Our prescription for them is to participate in a low to moderate activity, 50 to 30 minutes a day, 3 days a week. That is what our goal was for them. And we gave them some recommendations based on, and they could just pick what kind of exercise they wanted to, whether it's weight training, whether it's yoga, whether it's just walking, they picked it. What we wanted to do is have something they could do based on their physical ability, but also something that was sustainable for them. Like if we told someone to go, lift weights in the gym and they're like, I really hate weight training, they were not going to do it. So we let them pick what they wanted to do. But again, the research says any type of movement is what's going to show benefit. So just moving the body. And then we talked to obviously the importance of movement. Next slide. The next module was regarding toxin avoidance. We told them what toxins do to their body. Endocrine disrupting chemicals have a well-established positive relationship to not only PMDD, but also reproductive cancers, PCOS, endometriosis, and fertility. So we educate them on what the toxins were, how to avoid them, and we basically said avoid them to the best of your ability. So this was kind of a subjective recall, and most of them did pretty good in avoiding these things. We did discuss briefly what detox, how your liver detox. Again, knowledge is power, and educate as much as you can. They're going to take away what they want to, but we went over phase 1, phase 2, phase 3 of liver detox to make sure they were detoxing effectively. Next slide. And then we talked about how to swap things out, right? So parabens, phthalates being probably the biggest endocrine disrupting chemicals that we're going to see in functional medicine, the one that's most well studied. So those biggest sources are going to be skincare, cooking materials, the low-hanging fruit, like microwaving in plastic bottles, avoiding nonstick cookware, those kind of things. So we gave them the information and we told them what was the toxin in there, how to look for these labels on your packaging, but we also gave them some ideas to swap them out for healthy choices. Next slide. So we talked about food packaging and preparation. Next slide. And you guys will have access to all of this so you can see all the information I actually gave them. Next slide. And then water toxins and how to swap those out and avoid those, and airborne as well. So your phthalates that are coming from perfumes and detergents and those kind of things are airborne. Next one. Mindfulness and stress reduction. So there was a ton of information about mindfulness and stress reduction for PMDD, not just PMS, but specifically for PMDD. A lot of these studies, unfortunately, were old, so I had to pick and choose which one were the newer ones. But music therapy, very well established. Cognitive behavioral therapy, we know is very well established for PMDD cases. Unfortunately, it is just hard accessibility to get the cognitive behavioral therapy, and it's costly. So none of my patients partook in that, but they did choose another one. So again, the mindfulness and stress reduction, the prescription on the next page, you'll see, go ahead and zip that, was to practice a mindfulness, pick which one you want to do. Was it gratitude? Was it just reflection? Was it yoga, meditation, prayer, journaling, whatever that mindfulness looked like for them? We asked them to practice 15 minutes a day, almost every day of the week. And then supplementation. So the supplementation is all based on literature and research. So Vitex agonist castus, which we know is the taste berry, very, very well established. Some of you are going to use this for your PMS cases as well. Interestingly enough, this one actually, just because it's a regulatory progesterone and not so much of a progesterone stimulator, it does reduce PMDD, mood, and physical symptoms of the breast pain and tenderness and headaches at lower doses. Saffron is pretty well established. Unfortunately, saffron is not as sourceable, or at least I had a little bit more trouble sourcing it, so I did not actually use it in the study, but it is something you can use, and I've got your dose there that they're recommended. That study actually compared it 15 milligrams twice a day versus 20 milligrams of fluoxetine a day, and they had both really good outcomes, both of them statistically significant improvement in DRSP scores. And then we've got our phytoestrogen like black cohosh, does help because of their antioxidant and anti-inflammatory and antispasmodic effects of the brain. And then we've got our nutrients, our calcium, vitamin D, vitamin A. These are very well established. These studies are very old. Some of them were very old back in the 1970s. These were studied against PMDD. Vitamin A deficiency has been associated with PMDD symptoms. So is zinc and vitamin E. And then omega-3 fatty acids, we know all the wonderful benefits by reducing brain inflammation. And then also some B vitamins were important as well, predominantly because it supports those neurotransmitters. So these are the supplements that I recommended to them. The reason why I chose this manufacturer, which is Designs for Health, is because they gave them to my patients for free, which is amazing. So I contacted the rep at Designs for Health. I'm like, listen, you've got really good products. I want to be able to use them. I don't want cost to be a factor for my clients in the research trial. Would you please donate? And they did. So these are the ones that I studied. But again, these are the ingredients in these can be found in other manufacturers as well. So these most likely are going to be reproducible. It's the importance of the quality of the brand and then also the doses. And I gave you the doses here that were important. So we gave them omega-3 fatty acids. We gave them calcium and magnesium together. We gave them their fat-soluble vitamins A, D, K, and then we gave them a combination of herbs and nutraceuticals called FemGuard Balance. And there is a low dose of that DIM in there to help support that 4-hydroxy pathway as well. We could have chosen, 20 more supplements. I had to keep it limited for reproducibility and for sustainability. So you can, these are just for your information later, what's actually in the capsule, so you can move forward through those, Donna. And this is a summary slide. So this was the information they gave. I forgot to mention this earlier, but the platform that we use, this was all virtual learning. So this was not one-on-one learning. There was some accountability check-ins with my health coach, dietitian, but those were basically, if you have questions, call her kind of thing. I actually wanted to keep myself out of it to prove to other practitioners that it doesn't necessarily need a daily support from a practitioner. This is something that is plug and play for the normal community to be able to use and digest. So again, the key particles were these 5 different components. And then we gave them both information about why we're choosing this, what the research said, and how to implement these things. But this is a summary slide of why the key principles, what the intervention was, the frequency, and some examples. And these were our scores. These were our outcomes. So the letters at the bottom of the page were the actual clients. This is not what I published in the literature because they didn't want the actual specific clients. They just wanted a general approach. But I thought it would be interesting for you guys to see what my 9 clients experienced. The blue was their baseline. I did have another slide that showed all 4 cycles that are pre-intervention and post-intervention, but it's just too crowded for your brain to see. But you can see the improvement here. So blue is the baseline. Orange was the reduction in their DRSP scores. As a calculated. It was statistically significant, so that wasn't a successful trial. Generally, I think we had an average of about a 31% reduction. Our highest reduction was close to like 38 percentile. And you can see that SC, that one patient that got worse during the study. I called her, and before I got her results, I just called to check in on her. And she's like, I feel amazing. I've never felt better. I'm so grateful for this. Like, this was life-changing. Like, I never have to go on my medication again. And then I got her results. I'm like, what the crap? What happened here? And she basically said that pre-intervention stage, she's a teacher. The pre-intervention was in beginning of August, where she has not started school back. And then her post-intervention was when she was back in school. So we saw a very increase. I think she got up into the 50s for her DRSP scores the month she went back to school. And then they did taper back down from there. But she was my only client who got worse from her baseline. But she said, and that's an important key point, is that it's the stress. It was her stress of her job that drives her PMDD symptoms. And she contributed to other things like diet and lifestyle, the other outcomes, of course. But actually her stress got worse. And then after the intervention, where the stress stayed the same, those scores did eventually come back down. But she was the only one that didn't see improvement from intervention to outcomes. But, you know, her story that she tells is quite different. So we were happy with their outcomes. We were also compared it to pharmaceutical trials that use fluoxetine they use sertraline as their it was placebo controlled, but it was also using sertraline compared to placebo, and they saw about the same. They saw about a 38% improvement of outcomes. We showed an average of 31, but our highest, she was up to like 38 to 40. So it's pretty comparison of what pharmaceutical management does for these patients. So there were some barriers. So this is something for, as a practitioner, be aware of and go ahead and early intervene on these things. These are something that I did not intervene on because I wanted to get some feedback. What were the barriers to being able to do the program and stick with the program? Overall, we showed over an 80% adherence rate to the interventions, the diet, the supplements, the exercise, and all but the one. And basically that one person dropped down to 79 percentile. And she said it was just the meal planning was inconvenient. So if you can intervene early and say, hey, we understand that this is going to be hard, but if we can meal prep and give them resources on that, you're probably going to see even better outcomes. Toxin avoidance was about 80%. And that was the one rated her compliance with that category to 60%. She said she just couldn't find affordable organic produce. So giving them resources on how to get affordable organic produce, there's tools of the trade to get them mail order, that kind of stuff for your clients. Supplement adherence was pretty good. We had over 80 percentile there. We did have some GI side effects, so just kind of warn your patients. You may see some of that and how to modify it. Again, I didn't intervene, so she just stopped all of your supplements. Unfortunately, I feel like had she had a practitioner on board, we could have said, hey, let's see which one it is, and then kind of modified that, but she stopped them all. And then mindfulness, so recognizing that there are going to be some time constraints there. So I do think accountability is going to be big. So if you have a health coach, if you have someone to kind of help walk these people through, you're probably going to see even better outcomes. So as a takeaway, I'd say for sure, making sure you're getting a proper diagnosis, knowing the difference between PMS and PMDD, and then the acute stage and chronic stage, knowing what you can do. Remember, suicidality risk is very high in this population. So if these patients are in a very acute stage, knowing to recognize, hey, this is a little bit more than what we're going to get with diet and lifestyle at this stage. And sometimes you can intervene with the standard of care, which is using SSRI day 14 through 20 of their cycle. If you feel you want to play around with it, you can do the new medication that's on the market that we talked about earlier, those kind of things, or get a referral while you're doing the diet and lifestyle. Knowing to identify your triggers based on what we just talked about, like the diet, medications, hormonal fluctuations, and stress, correct any imbalances that we're seeing with their neurotransmitters and their hormonal imbalance, support their detoxification, making sure they're moving their bodies, making sure they're managing their stress, and then accountability and feedback are going to be huge. So making sure you're keeping them accountable and checking in on them frequently. This is my references. I have about 60 pages of references. These are the ones that were the big ones. So I went ahead and putting them here for you that you cannot see, but I have access to all of these if you're interested in learning more. So thank you so much. I know that it was a long presentation, a lot of pathophysiology here, but I hope that there was some good takeaways and pearls that you can use. So I'm going to take some questions now.
Um, Speaking of questions, and thank you so much. That's fantastic. You've given us a great foundation on how to distinguish between PMS and PMDD and some approaches we can take. And Dr. Same is Sima, and I always struggle with her name. I'm so sorry. So, okay. How long was the program and how many touch points did you have?
They were those, I think by touch point, you're talking about like how much interaction I had with the clients. So I'm going to answer it that way. 0. So the only one I did at the very end is like, you're done with the program. How do you feel kind of thing? Cause I wanted to be, I plan on, not just publishing this stuff, but when you're talking about scientific journal articles, they just want to see your research, right? I really want to publish this in more of a case study base where practitioners and individuals can actually learn from what they experienced. So I did do like an interview style after the fact and recorded that for my clients that went through the program. So that's the only time I actually touched them. Now my health coach dietitian, because I didn't want to be so medical, this is how clients do. They grab you like, oh, by the way, can you prescribe me blah blah blah, or by the way, I've got a yeast infection, yada yada. So I wanted to keep myself out of it for that very important reason. But the health coach, she would probably tell you that she maybe talked to most of them 4 or 5 times, maybe once a month, just to check and see how things were going. But as a practitioner, very little involvement with me. It was all my care plans. I created everything except for the recipes. That was a dietitian. Other than that, she was usually their point of contact. And it was a 16-week mini research trial, and it was 12 weeks of intervention and 4 weeks of data collection before.
Okay.
Not pharmaceutical, Desiree, that's a great question. Haven't seen a huge need for it yet, but that is something on my radar. I don't feel like I'm scared of it. I do feel like I'm confident, and if I had to use it, I could use it in this patient population, but I don't have any clinical outcomes with it yet. It's fairly new to the market too, so there's just not a lot of clinical outcomes out there that you can kind of read about, unfortunately.
So what we see is that your trial, your approach is giving better results than the conventional approach. And what is so frustrating and so sad for these women is that I haven't heard this stuff really taught anywhere. What's the difference between PMDD? What, you know, some of the things that we use for PMS could make the PMDD patient worse.
Right.
So I'm excited that you have pulled all this information together and done the hard work. So thank you so much. So let me ask please, everybody, feel free to unmute yourself or put a question in the chat if you do have questions. So okay, so your trial was diet. Okay, you got great results: diet, movement, toxin avoidance, mindfulness, stress reduction, and the supplements. Would you, if these were patients that you were seeing in your hormone functional medicine practice, would you have added anything else? I mean, because your patients in the trial, did you do Dutch testing and any time? Okay, so if you were seeing them as a patient, would you do those things initially as well? Okay.
Yeah, and that's a really good point. And I forgot to mention that I had it in my notes, but I couldn't see it on your screen, so didn't have access to that. But it's thyroid screening, right? So we need to make sure that there is a thyroid panel on these patients to look for comorbid conditions and make sure there's nothing going on there. I think it is important to look at their adrenal glands. I think it is important to look at we have access to these labs, why not use our precision medical and information and really create a care plan that we're not just giving 1,200 milligrams of calcium because the clinical trials say to. We can specifically see if they're calcium deficient and help them support them in that way. Same thing for vitamin D. Like you can certainly personalize these programs, and I encourage you to do so. But this is if you have no access to that. You don't have access to these other things. You're just doing diet and lifestyle and more of a general approach, then yes. But most of the providers will use their clinical insight and expertise to say, you're going to get even better results if we can personalize it to that particular patient.
Yes. So that would include cortisol testing, thyroid testing, glucose metabolism, your fasting, the usual things that we teach at the academy, D, ferritin, all of that.
all
Would you
that.
do neurotransmitter testing? Would you do nutrient deficiency?
I think that you possibly can. I think that that is an option if it's not a cost prohibitive, but again, looking at those levels, right? It's not as much of a serotonin issue. It's not as much of a norepinephrine, not as much of the dopamine. They're there, they're contributing, but we're really more focused on that GABA glutamate system. So yes, you can certainly do those baseline and intervene if you need to. You can kind of tweak, if you're using L-theanine or using more tryptophan, more vitamin C to kind of help with those neurotransmitter support. So yes, I do think that if you can have access to those labs and run those testing, that would certainly be beneficial for your clients.
And then implement like the foundational things that you put in there.
Yeah.
So speaking of theanine, that helps push glutamate off its receptor.
Mhm,
I
mhm.
understand. Okay. All right. So you've brought up something about progesterone because oral progesterone converts more into allopregnanolone than topical or vaginal. So you want to talk through that a little bit more just to
I know
solidify.
you're Yeah, I knew you were gonna ask me this question. I have not typically used that with my clients. Again, 2 to 8% of the population. I haven't had a robust amount of new patients coming in where I can actually modify these things. So I've changed a couple of them, learning what I have learned from their oral because I was giving them oral, thinking it would help. And then now I'm like, gosh, man, that's the thought that I had is maybe we can change them to transdermal if they're truly deficient in progesterone. If they're not deficient in progesterone, then should we really be supplementing these progesterones? I'm going to have to say no. I'm going to say probably not going to make them feel any better by giving them progesterone. Now, if they are progesterone deficient, if they are estrogen dominant, I would say that choose probably your estrogen metabolite support first. So helping flush out that extra estrogen, like your DIM and your I3C. I would say do your adrenal support first, helping modulate the cortisol and the blood sugar. Do your thyroid optimization first. And if that fails, then I'd say probably a low dose of progesterone. If you have labs to confirm your progesterone is deficient, that would be probably a better option than doing an oral, yes. But again, these are the cases that I would say do your other stuff first. What we don't want to do as practitioners is make them worse instead of making them better.
And if someone gives oral progesterone and they get a negative report, like, "Er, let's switch, let's switch." Okay, so PMDD, the age range, because I can see where it's going to be real critical to help, when somebody comes in, because you're going to get these patients. I've got an awful case of PMS. My husband's going to divorce me if I don't, whatever. Distinguishing between the PMS and the PMDD. Is PMDD the more younger? Or does it get better as women approach, menopause?
It's a very good question. It does not get better. It gets worse perimenopausally. You're going to see that because the fluctuations are so much more dramatic at that time period. The estrogen, progesterone, they're so much more dramatic. So it does get worse perimenopausal. The cure for PMDD is menopause. Once you stop producing those endogenous estrogens and progesterones and you have a steady state, then you're going to see resolution of their symptoms. Or you can certainly give them hormone replacement therapy. That's another good key point. You can give them hormone replacement therapy after menopause, but again, you want to make sure your levels stay as consistent as possible and they have less of those peaks and troughs, or the symptoms can come back. So you want to try to avoid that at all costs. PMS can happen at any age. We typically see that onset a little earlier. We're going to see that in their adolescence, maybe their early 20s. Again, the PMS is more the progesterone deficiency. So they're not having enough ovarian reserves, or they're not ovarian reserve, but ovarian production of those endogenous hormones. They have a lot of stress, so they're having that cortisol still as well. But PMDD actually onsets more in your 30s. That low 30s is typically when you see that. That's why some of the theories around it being more of a reproductive issue is because it did seem to happen after women were having children. I don't know if that's just more of an inflammatory response. I don't know if that's more of a nutrient deficiency. All those nutrients, the calcium, vitamin D levels all go to baby, and then those women never really build their stores back up. We don't really know what's happening there, but we do seem to see that the PMD actually onsets in the early 30s, and it continues into their 40s until they actually stop and go through menopause.
Interesting. Okay, Desiree's got a question. Can you see the chat, Diana?
Yes.
Okay.
Are you more likely to jump with thyroid support like Armor in those iffy patients with PMDD, say a TSHs and the twos? Have you found thyroid hormone helpful in PD? I would say I've seen thyroid replacement and PMS very, very helpful. I have had a case where I did everything else for a PMDD. Now, this was pre-clinical trial. This was knowing what I know about PMDD. She was on oral progesterone, but I had a patient that was the only thing that we tried with her that we had not tried. We did the adrenals, we did the insulin, we helped her lose the weight, we detoxed, we did all the other stuff. Her TSH was like 2.2. I'm like, hey, let's just throw some R at it. Let's see what happens. She didn't respond. She didn't respond at all. She stopped taking it. She gave it 30 days. I'm like, can we try another 30 days? She said, no, I'm not spending the money. I didn't see any results. So that's kind of how that ended. So I don't know if you're going to get a whole lot of results. Again, as practitioners, we know that if we have a suboptimal thyroid, then yes, we need to treat that. But I would not put all your eggs in the basket thinking that a suboptimal thyroid, you give it thyroid replacement and you're going to treat PMDD completely. I don't think so. I don't think it's just a thyroid issue.
You want to do all the things, all the approaches.
Thing on inflammation, that is the key for almost all these receptors in the body. When we looked at that conversion, if you upregulate those enzymes or if you block the receptor, inflammation is always at the key, always at the root. So that's why you have to work on the inflammation.
Yeah, makes sense. Any more questions for Diana? Okay, this has cleared up a lot of questions and a lot of patients that I feel like we haven't equipped the providers well in helping. So this is fantastic. I'm so excited that you did all this and that you shared it with us. You shared it with us before you put it out into the world, so we appreciate it. Okay. All right. Any last thoughts? Any follow up on that from anybody?
Sorry, can I ask one question real quick?
Sure.
It might be quick, but I have like a patient in mind, but she is currently on birth control. So she's been, obviously treated conventionally. So she's on birth control and then also an SSRI. Like, how do you handle transitioning these people over to more like natural therapies? That I don't want to like just suddenly stop somebody on their birth control and SSRI, obviously. So I don't know if you guys have any experience with kind of converting, if you will, but
I would say because it was really the 12-week mark of intervention where we started seeing some really good numbers coming down. I would say 12 weeks of these therapies, 12 weeks of these interventions, making sure they're adhering to their food plan, making sure they're, anti-inflammatory diet, they're taking supplementation. If it's their goal to wean off of the things, I think I'd probably take them off the birth control first.
okay.
And that stabilizes, I'd say maybe 30 days later, then you can start to wean down on their SSRI. Again, if it's their goal, let that be their goal. You don't want to say you need to come off your meds. That's not something you want legally on your page, but
Sure.
I think that would be my attempt to get them off the birth control first. We had 2 patients, I believe, in the PMDD program that I did, the research trial that I did, they were on birth control. One of them stopped it on her own. She's like, I don't want to take it anymore. She was just looking for this little ounce of hope. She felt a little bit better for the first one and she stopped it. And she still progressed to have better numbers, the DRSP scores, even after the birth control stopped. I did not advise that. I did not follow that, but that was her choice. She did actually still coming off the birth control.
Okay, great.
SSRIs. I think I had one that was actually out on the SSRI. And I don't think she stopped it, but so yeah.
Sure. Okay, great. Thank you so much.
I think that's very logical. Try the 12 weeks intervention with these supplements and then work towards the next steps or whatever, getting them off. Because a lot of women aren't going to want to get off. It's like you showed the statistics. Most women would prefer the natural approach, but they've got to have something, and they've got to have somebody to help walk them through and get to where they need to be. So
they're looking for these therapies. They're looking for someone to be able to help them through that. Absolutely.
That's why I'm so excited you did all this research. It helps us all. So thank you so much. Okay. Unless there's any last minute questions, we will let the busy Diana go, and you guys are busy as well. So thanks so much, everybody. Thank you again, Diana.
You're welcome. Have a good day.
Thank you. Yeah, it was so good.